Welcome. Thank you for joining us today. There are a couple more folks joining us, so we'll take a second to get started. Really great to see folks. I've put a message in the chat that if you'd like to introduce yourself to our speaker this morning, feel free to use the chat function by entering your RICMOR or your institutional affiliation. It'll give her a sense of who's joining us. All right, on the next slide, let's go ahead and get started. So good morning, everybody. Good afternoon for those on the East Coast. This webinar is being hosted by the National Coordinating Center of the RICMARs at UCLA. With funding from the NIA, the Coordinating Center at UCLA works to disseminate RICMAR processes, tools, and research results to actively demonstrate the RICMAR's impact upon the health of minority adults in the U.S. As a land-grant institution, UCLA and the RICMAR Coordinating Center acknowledges our presence on the traditional ancestral territory of the Gabrielino Tongva peoples. We hope you can take a minute to acknowledge the ancestral lands you are currently on as we get started today. The staff at the Coordinating Center work really hard to provide you with updated information about opportunities and resources related to aging and diverse communities. So we really invite you to visit our website regularly for updates and announcements and to follow us on social media. Next slide. For those who celebrate, Happy Hanukkah. I acknowledge that today may not have been the best day to schedule our webinar, and I take full responsibility for this scheduling faux pas. Moving forward, I will try my best to avoid religious holidays when we schedule our webinars. But Happy Hanukkah for those who celebrate. Next slide. Just a few reminders before we begin. Please note that we are using Zoom meeting for today's webinar. That means that we can see and hear you. Please, again, take this time to introduce yourself in the chat function so our presenter sees the breadth of folks that are participating. Also, please make sure that you are muted throughout the presentation. This will facilitate our recording. We will distribute today's slides to registered participants, and we will post them on our website after this session. We have a great presentation in store for you today. I'm sure some of you already have some questions that you're interested in asking our speaker. So please take note that we will be monitoring the chat function, so feel free to submit your questions there. Feel free to enter your questions as she is presenting, and I will monitor those and curate those for her. And if not, then we will have time at the end of our presentation for all of your questions. Next slide. So it is really my pleasure to introduce Dr. Marvella Ford, who's here with us today. Dr. Ford received her MSW, MS, and PhD and postdoctoral training at the University of Michigan in Ann Arbor, where she was awarded both pre- and postdoctoral fellowships from the NIA. Subsequently, she held faculty positions at the Henry Ford Health System in Detroit, Baylor College, and the Baylor College of Medicine before coming to MSUSC and the Hollings Cancer Center. Her training in the social determinants of health affecting disease and its treatment has uniquely positioned her to take a leading role in tackling a distressing and incompletely understood public health problem in the state. The fact that societal differences in the population can lead to markedly different health outcomes for members of diverse racial and ethnic groups, which is exactly what the RICMARs are all about highlighting. And so with that, we are looking forward to hearing from Dr. Ford today. Dr. Ford, feel free to share your slides. Welcome and thank you.
Good afternoon, everyone. It's a pleasure to be here with you this afternoon. It's unfortunate that we're talking about this topic that I think we can come together and hopefully develop some strategies to address this issue. So it's, again, a great pleasure to talk with you today about COVID-19 and the social determinants of health disparities in older adults. And thank you so much for that very kind introduction. Before we get started, let's make sure that we're all using the same definition of health disparities. So the NIH, as many of us know, defines health disparities as differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the United States. We also use the terms health care disparities and health status disparities. And in the course of today's presentation, all of these terms will be used or referred to. So health care disparities refer to differences in access to or availability of healthcare facilities and services. And health status disparities refer to the variation in disease occurrence and disabilities between socioeconomic and or geographically defined population groups. Next, let's discuss COVID-19 for a moment. So the coronavirus, COVID-19, we know that it's an illness. It's caused by a virus and it can spread from person to person. What makes coronavirus different, what makes COVID-19 different from other viruses is that it's new. No one has immunity to this virus. And so we know that there's a lot of misunderstanding in the community about COVID-19 and what it means, what immunity means. There's a faction of the population that is interested in developing pre-vaccine herd immunity, which, as many of us know, would cause just a large number of deaths. So we have a lot of work to do in educating our communities about what COVID-19 is, how it spreads, and what the vaccine can do to prevent the spread of the disease. COVID-19 symptoms can range from mild or no symptoms to severe illness. So what are the racial disparities in COVID-19 cases? Well, I pulled the data. The most recent data I could get from the Berkeley project are from November 22nd. And in this map, the redder the state, the higher the racial disparities in the state. What we do know is that predominantly Black communities in the United States bear the burden of the country's COVID-19 cases and deaths. And we can see that using data from the United States. So this graph represents the proportion of each racial and ethnic group listed here in the US. And when we look at COVID-19 infections, we see that Latinx and Blacks have higher rates of COVID-19 infections than whites, but it's when we look at deaths that we see that compared to their representation in the general population, Blacks are highly overrepresented in COVID-19 deaths. And Latinx populations, even though they have a higher rate of infections than Blacks, have an equal rate, percentage of deaths. So what does that mean? When we look at COVID-19 by race ethnicity, if we look at cases compared to non-Hispanic whites by racial and ethnic group, we can see that American Indians or Alaskan Natives are severely impacted by COVID-19 infections compared to other groups. Hispanic or Latino or Latinx groups also have a high rate of infection. When we look at hospitalizations, again, it's American Indians, now Blacks as well, and also Hispanics or Latinx groups. And Blacks are also affected by new infections. But when we look at deaths, Blacks really stand out as having the highest rate of deaths than any other racial or ethnic group in the country. What are some of the contributors? So, today we're focusing on the social determinants of health disparities, and one of those determinants is neighborhood characteristics. And we know that in Black communities, quite a few, there's a high percentage of multi-generational residential arrangement. in the Black community, where you might have a grandparent, a parent, and a grandchild all living in the same household. What does that mean? That's often done for socioeconomic reasons or for cultural reasons. But in terms of COVID-19, the implications are if one person who lives in a house that has 6 people and 1 bathroom takes a COVID-19 test and they're found to be positive and they're told to quarantine, how do they do that? Where do they go to quarantine? They're living in a house and there may be an older person in the home with them that they definitely need to stay away from, but they're sharing the same bathroom, they're sharing the same physical space. So there are a lot of factors that go into the higher rates of COVID-19 deaths among Blacks, and we're going to talk about those today, particularly in relationship to aging. So this map shows where these are health conditions in the United States. And what we can see, we can see that the darker the purple, the higher the rate of chronic conditions in a particular state. So let's take South Carolina as an example, which is about here, which is has a lot of purple in it. So that means a lot of chronic health conditions are among the residents of the state. When we look at the population of South Carolina, we can see that the state population is about 5 million people, and it's fairly evenly divided between males and females. When we look at the South Carolina data to the left compared to the US data to the right, we see that a higher percentage of the region in South Carolina is rural compared to the US as a whole. And in fact, out of the 46 counties in South Carolina, 75% of those counties have areas that HRSA designates as rural. We'll talk about the implications of that. South Carolina also has a higher percentage of Blacks than the US as a whole, 27% compared to 13%. And we have a small but growing percentage of Hispanics, Latinos, or Latinx, 5.8, almost 6% compared to 18%. We are not a state that has achieved high levels of education compared to the US as a whole, and that's reflected in the lower income levels of people living in South Carolina compared to the US. And you can see the differences in median household income between whites, Blacks, and Hispanics or Latinos. When we look at poverty level, South Carolina has a higher percentage of people living in poverty compared to the US as a whole. We also have some unique characteristics. We've discussed our rural population that is related to transportation issues, to testing sites, to healthcare sites. We have issues with distance to specialty care sites, as well as access to clinical trials. In this case, I was referencing cancer trials. And we have a unique population called the Sea Island or Gullah population. And these are Africans who are primarily from the west coast of Africa. Many are from Sierra Leone. And this group is very genetically and culturally distinct. They had a lot of geographic isolation and low rates of genetic admixture. Their rate of admixture is 3.5%. That's the lowest of any group of Blacks in the United States. For today's presentation, this group is highlighted because they tend to be medically underserved and live in rural areas. What are the impacts? Well, when we look at COVID-19 in South Carolina, the data from yesterday showed that our positive rate was 21.3%. So that is a very high rate, and we're similar to other areas of the country, but this is definitely a major issue. When we look at where the COVID-19 cases are in South Carolina, we can see that there's a cluster up in the Greenville area where the BMW North American headquarters is located, and also in the Charleston region. But there's a wide swath of a geographic region here, which is the I-95 corridor. And you can see that the darker the blue, the higher the incidence of COVID-19 cases. So what is the I-95 corridor? It's the corridor of economic disadvantage. It's also been called the corridor of shame because it is very economically underdeveloped It's not only one of the most economically underdeveloped regions of South Carolina, but of the US as a whole. And so if you've ever driven on the I-95 corridor through South Carolina, you know that there are very few businesses, there's very little industry, very few hospitals, just a rural, medically underserved region. And that is reflected when we look at, so we know that many of the COVID cases in South Carolina are located in the I-95 corridor, and that's tied to the social determinants of health. Because when we look at the areas of need in the I-95 corridor, we can see that compared to the rest of the state, the I-95 corridor has more counties with areas of need. These are economically and medically underserved regions, economically depressed, medically underserved regions. And the red indicates high need, the orange indicates neighboring areas. So that's the I-95 corridor. When we look at poverty in the I-95 corridor, we can see that there are high rates of poverty, child poverty as well as total population poverty. So child poverty is represented by the light blue, and the darker blue is total population poverty, clustered in the I-95 corridor of the state, where the COVID-19 cases are also clustered. And here, when we look at who lives in this I-95 corridor, when we look at the percentage of white people who live in the I-95 corridor, we can see that here, the darker the purple, the higher the percentage of white residents. There's not much purple in the I-95 corridor. You can see a lot of darker purple clustered in the Greenville area. There's a lot of industry. This is a very economically well-developed region of the state. And also in Charleston, many people are familiar with Myrtle Beach and Hilton Head. So there are clusters of whites along the coastal region, but in the I-95 corridor, what we see is that most of the residents of the I-95 corridor are Black. So this map shows the percentage of Blacks who live in the I-95 corridor or in the rest of the state. The darker the green, the higher the percentage of Blacks. And again, you can see these areas of economic need highlighted in red that correlate with the percentage of Black residents living in the region. When we look at the urban-rural status of the state, we can see the dark green represents rural, and again, the I-95 corridor is very rural. So this map shows, so we want to ask the question, we've discovered that the I-95 corridor has some of the highest rates of COVID-19 infection in the entire state. We have determined that the I-95 corridor includes a high percentage of Black residents. What are some other chronic conditions that affect people living in the I-95 corridor? Because we know that having chronic conditions puts people at risk of developing COVID-19. So when we look at diabetes prevalence in the state, it's also clustered in the I-95 corridor. So again, the darker the blue, the higher the prevalence of diabetes. And interestingly, when we look at diabetes death rates in the state, they're driven by Black men. And what we'll see is that most of the disparities in the state are driven by Black men. So here we're looking at heart disease mortality rates. The darker the red, the higher the prevalence. And again, it's the I-95 corridor that stands out. And when we look at age-adjusted heart disease rates in South Carolina, again, those death rates are driven by the rates among Black men. We consistently have the highest death rates compared to any other racial or gender group. And that's true for HIV infection as well. So let's turn to cancer. This map just shows the prevalence of cancer. Actually, I think it's incidence of cancer in the United States per 100,000 people. We just recently developed a report called Cancer in African American Men in South Carolina. The state had never before published such a report. But when we looked at the cancer data, we saw that we needed to focus on Black men. And so we partnered with our state health department. And what we showed previously in a previous report was that when we look at all cancer 5-year age-adjusted incidence rates trends by race and sex, we can see that Black men are really driving disparities in the state, followed by white men, white women, and Black women. These are incidence rates. When we look at the mortality or death rates, we can see that once again, Black men are in the lead, followed by white men, now Black women, and then white women. So all of those factors contribute to the COVID-19 data among Blacks and Hispanics or Latinos. And when we look at Blacks in South Carolina, again, comprising 27% of the population, but 30% of the cases and 37% of the deaths. Hispanics or Latinx, 6% of the population, 11% of the cases, but 4% of the deaths. So I think there's a lot of work that needs to be done to explore these relationships, but this is very clear. When we look at the projected deaths in South Carolina, we can see that they're projected to increase significantly between December and April. And then these are the daily death projections. So what is the relationship between aging and COVID-19? So we know that older adults are at greater risk of requiring hospitalization or dying if they're diagnosed with COVID-19. The risk for severe illness for COVID-19 increases with age, and older adults are at the highest risk. And this risk increases by decade. So if you're in your 50s, you're at a higher risk than people in their 40s. People in their 60s and 70s are at higher risk than people in their 50s. And the people at greatest risk for severe illness from COVID-19 are those who are aged 85 and older. So what does that mean? If we use the 18 to 29-year-olds as a comparison group for both hospitalization and death, you can see that the rate of hospitalization increases significantly from 30 to 39 years of age to 85 years. So those 30 to 39 years have a hospitalization rate that's twice as high as for those 18 to 29 years old. And people 40 to 49 years old have a rate 3 times higher, and it just keeps increasing. When we look at the deaths, the data are really kind of startling, because here we can see that people who are 30 to 39 years have a death rate 4 times higher than those in the 18 to 29 year range. And then it increases to 10 among those 40 to 49 years, 30 times higher among those 50 to 64 years, 90 times higher among 65 to 74 years, 220 times higher among 75 to 84 year olds, and 630 times higher among people 85 plus years. So we know that certain medical conditions can increase risk. And we've been told, and we know the data show it, that people with underlying medical conditions are at greater risk of having severe COVID-19 outcomes. So there are many diseases that have been shown to definitely increase the risk for COVID-19, and these diseases occur more commonly among adults who are aged 50 years and older. And these include cancer, chronic kidney disease, COPD, or chronic obstructive pulmonary disease, heart conditions like heart failure, coronary artery disease, cardiomyopathies, obesity, severe obesity, smoking, and type 2 diabetes. So we have seen the relationship in South Carolina between the prevalence of many of these chronic conditions and COVID-19 outcomes. And that's true for the nation as a whole. There are other diseases that might increase the risk for severe COVID-19 outcomes. And those also, many of these also occur more commonly in adults aged 50 and older, such as cerebrovascular disease, hypertension or high blood pressure, neurologic conditions such as dementia, liver disease, overweight, pulmonary fibrosis. So there is an association between the chronic disease and COVID-19, and older adults are more likely to have chronic disease. These graphs show excess deaths. So this is a comparison of the deaths from 2015 to 2019 compared to those in 2020. And you can see that the excess deaths are much higher in older people than in people who are less than 25 years of age. And this has all happened just in 2020, just in the last few months. We can also see a relationship between deaths and COVID-19 deaths and age, where the deaths are clustered. Even if we look at people 55 to 59 and increasing. And I just wanted to show a snapshot of data from South Carolina. These are from December 8th of 2020, just showing the deaths that took place. So we can see that some deaths were probable, some were confirmed. Probable means that they still had to actually do the testing, but these deaths were likely linked to a COVID-19 infection. And these are the counties in South Carolina where the deaths occurred. And you can see that, you know, we don't like the term elderly, but that's what's used in this report, 65 and older versus middle age 35. This person was 35 to 64 years of age. And the 3 remaining people were 65 and older as well. So what are the social determinants of health, and how do they contribute to COVID-19 disparities in older adults? Healthy People 2020 defines social determinants of health as conditions in the environment in which people live, learn, work, play, worship, and age that affect health, functioning, and quality of life outcomes and risk. And we know that there are place is referred to as the condition, whether they're social conditions, economic conditions, or physical conditions that affect health outcomes. And we have talked about the example of the I-95 corridor. So you can imagine that if you live there, there are not many grocery stores in that region. There are not many hospitals in that region. There are not many after-school activities for children in that region. There may be a few gyms, but we've looked and there aren't as many gyms or recreation centers there as in other places. So all of those factors contribute to health outcomes. And then we have social engagements and a sense of security and well-being, the feeling of safety. We think about Maslow's hierarchy of needs, and the bottom level is just the question is, in Maslow's hierarchy of needs, is our basic needs being met? And so we know that with the pandemic, we know that food banks are full, people are lining up to get food, distributed food. There's a lot of food insecurity, but the reality is that for many people who are most severely affected by COVID-19, this is not new. That have already job insecurity for decades. And so what is new to many communities may be intensified for other communities, but it's not a new experience. I remember watching CNN, and there was a woman who was driving a really expensive car, and she was in line to get food at a food bank. And she said never in her life did she ever think that she would have to go to a food bank and get food. But the pandemic caused her to lose her job, and she didn't have any food at home. And we've seen the images of many people who are affected by COVID-19, the economic impact of COVID-19. But that economic impact, that feeling of insecurity and lack of well-being, has been experienced by many communities for decades. It's not new to them. Some other social determinants of health are living in densely populated areas, experiencing residential segregation, and looking at communities, not living close to grocery stores, and medical facilities. We saw that in the I-95 corridor where there were areas of need. The basic elements that support a healthy life are lacking, and they were lacking before the pandemic hit. And then we also look at multi-generational households, and we know that these are more common among some racial and ethnic minority families. You know, they serve a purpose. If you have two working parents and a grandparent in the home, the grandparent can help to watch the children and take care of the children. But when a pandemic hits, and then you have older people in the home, younger people in the home, how do you separate? And there's not much space in the home. How do you quarantine? So those are some issues that are being faced in our communities. We also know that racial and ethnic minority groups are overrepresented in jails, prisons, and detention centers. And this is where a lot of members of these communities are dying. They're being infected and they're dying. So how do social determinants of health affect us over the life course? We know that David Williams and others have published data showing that the experiences of our early childhood affect our health outcomes as adults and as older adults. So that even if you started off in a lower income bracket and you moved to a higher income bracket as an adult, those early life experiences still affect your health outcomes as an adult. And so when we look at some factors that affect the social determinants of health, we look at environmental factors, social environmental factors that influence susceptibility to disease. Here we've talked about the physical environment, the social environment, multi-generational households. We've talked about access to high quality food, access to recreational facilities, access to high quality schools that lead to jobs that actually provide health insurance coverage and sick days and sick leave. So those factors influence susceptibility to disease. We know that what we eat, whether we exercise, all of that affects our health. And then these factors also affect our access to healthcare. So there are many people pre-pandemic who worked maybe one or two jobs and still didn't have health insurance coverage or adequate health insurance coverage pre-pandemic. So that lack of access to healthcare affected their health status and their susceptibility to chronic diseases pre-pandemic. And when you have these factors occurring over the life course, that ultimately affects health. By the time we're 40 or 50, that affects our health. And on average, many chronic conditions tend to be diagnosed in Blacks about 10 years earlier than whites. And a lot of it may be due to these factors that contribute to susceptibility to disease, lack of access to healthcare, and health disparities. This is a model that Keith Whitfield Edwards and I published back in 2014 in his book with Tamara Baker called "What Does Knowing About Genetics Contribute to Understanding the Health of Minority Elders?" And all of the models that I'm going to be showing are from our previous publication. So this is a slightly more complex model where we have structural life inequalities. We have lack of access to high quality education, lack of access to good food, lack of access to physical activity areas, and those lead to chronic stressors. And over the life course, when we are constantly stressed, those can lead to behaviors to cope with the stressors. And I know that I've talked with a lot of colleagues in the academic setting who said that they're feeling very stressed because of COVID, and they're drinking more alcohol or they're eating more comfort food. So we've been dealing with COVID for about 12 months, well, about 8 months now, 8 or 9 months now. And we're talking about well-educated people who are engaging in behaviors to cope with the stressors. Imagine a community of people dealing with these stressors every day pre-pandemic. This was just the way of life. So an example is you finally, a person is interviewed, they finally get a job. The job requires them to drive. They have a car, but it's old. So they're just hoping that the car will be able to get them to and from work. But because the car is old, it breaks down a lot. It makes them late for work. So they call their employer, and the employer says, you're late again? And after a while, you lose the job because you didn't have the transportation to get you to the job. So people live, catch-22, they live with these stressors a lot. And so what is a minor inconvenience for most of us? Oh, my car broke down. I'll call AAA, I'll have it towed, I'll get it fixed. It's an inconvenience. It makes us reschedule our day. We may have to postpone some meetings, reschedule things. That can lead to job loss for other people. Job loss leads to not being able to pay the rent. Not being able to pay the rent leads to not having a place to live or feed your children. So some people engage in behaviors to cope with these chronic stressors, and those in turn can lead to other types of disparities around behavioral health. And then we have the final model that we have put forth, where we have the environment, we have neighborhood effects, noise, urban areas, or rural areas. And when we think about these factors over the life course, stressors, job stressors, family stressors, financial stressors, and relationship stressors, we know that having a lack of financial stability puts a lot of stress on our relationships in the family, with friends, and it's a very difficult position to be in. And when that is chronic over the life course, it takes a toll on our health. And experiencing these negative social determinants of health over the life course puts people at risk of COVID-19, leads to disparities in COVID-19 outcomes. So when we have these stressors, then again, we engage in these poor health behaviors that temporarily help to relieve the stress, but in the long term lead to physical health disorders, diabetes, cancer, organ damage. And the reality is, even if we don't engage in the poor health behaviors, the stressors themselves still can lead to physical health disorders. Just having the chronic activation of the hypothalamic pituitary adrenal axis, that fight or flight syndrome, constantly elevated levels of inflammatory biomarkers, leads to organ damage. We have the downregulation of the immune system, meaning that our immune system isn't functioning optimally, making us more susceptible to disease and infections. And then also we have the outcomes that are associated with negative health behaviors as well. But even exclusive of these behaviors, chronic stress still has a major impact on physical health. And so you imagine somebody who's 40, who's been dealing with all of these stressors all of their lives. By the time they're 40, they're already dealing with chronic diseases, diabetes, cancer, organ damage, kidney disease. And so we look at COVID-19. We know that it's taking a major toll on Blacks, Latinx groups, American Indian groups, but for Blacks in particular, the death rates are just devastatingly high. And so there may be some type of biological component, but it's most likely working through the social factors of stress, this chronic stress that people are dealing with in their day-to-day lives that predispose people to the chronic conditions by the time they're 40 over the life course, but also may predispose people to COVID-19 infection in addition to these other social factors. So I just wanted to stop and take any questions, and I also wanted to remind people of symptoms of COVID-19. And we are thankful that the vaccine will be made available in 2021. But thank you very much for your time, and I will stop and take questions.
Thank you so much, Dr. Ford. That was a great presentation for us. There's one question that just came in through the chat from Dr. Fazio at the NIH. Dr. Fazio, would you like to state your question? You can use your phone to ask. Thank you.
Great. Thanks so much for your presentation. I know it's such important work. And thinking about COVID, one of your earlier slides, the one that was titled Relationship Between Aging and COVID, the slide itself talks about that many of the diseases that increase risk for COVID occur more likely among older adults. And then out loud, you noted, though, that that these diseases may increase really the risk for what I would say, and you said, were severe COVID outcomes. So I'm just curious if you're saying both things, that these diseases potentially add to the risk of getting COVID, as well as the risk of severe COVID outcomes.
That's a great question. Thank you. You know, when you look at immune function and you look at who's at risk of developing COVID, people with underlying health conditions already have issues with their immune function. So that puts them more at risk of developing COVID, as well as having more severe outcomes when they are diagnosed. And a lot of it is because of their immune system isn't functioning optimally when they're diagnosed, isn't functioning optimally, making them more susceptible to a COVID-19 infection, and also more susceptible to more severe disease outcomes from a COVID-19 infection.
Great, thank you so much.
Thank you.
Any other questions or comments for Dr. Ford?
I've got a question. Marvella, this is Mike Cummings. Nice
Hi,
presentation.
Thank you.
One of my questions, and it relates to the age-related effects, is, you know, how much of the difference there is due to perhaps underdiagnosis in the young? You know, they're not receiving regular health care versus those who are older and have comorbidities who are more likely to be diagnosed. And then, of course, among the you know, the older population, they're more likely to be housed in locations where spread, like nursing homes and assisted living and those kinds of things, where we've seen a number of the outbreaks here in South Carolina.
Mm-hmm. That's a great question. So let's look at the first one. When we look at younger people, most younger people who are diagnosed with COVID-19 and have an infection have a very robust immune system, and they may have very mild symptoms. But the younger people who have underlying conditions like asthma or another type of chronic condition at a young age tend to have poorer outcomes from COVID-19. So to answer your question about maybe undiagnosed, there may be some young people who didn't know they had an underlying health condition, and those young people are the ones who have the poorer outcomes. But from what I'm reading, quite a few of the young people who are battling severe COVID infections or disease knew they had an underlying health condition. They knew they had whatever it was, lupus or whatever the condition was. There may be some who didn't know, though. I mean, we've seen that with young people playing sports, you know, where they suddenly go into cardiac arrest. They didn't know they had an underlying condition, but it seems like most of the young people knew they had this underlying condition. And then your question about the assisted living, that definitely goes into the residential issue. So when you look at COVID-19, residential issues affect likelihood of infection, because, when you look at people being crowded together, whether you're in an assisted living facility or you're an inmate in a prison or a detention center, it's similar, and I don't want to make it seem like they're similar in the sense that you're sharing bathrooms, you're sharing, there's a lot of opportunity for transmission of the virus in those crowded settings where there's a lot of sharing of people in and out of shared space and shared restrooms, shared community areas. So great point. I hope I've answered your question.
Yeah, you did. Has anybody done a antibody study, community-based? So you actually have population estimates of exposure? So infection, in other words.
Yeah, that's a great question. Not to my knowledge. Maybe someone else knows of a study, but that would really be a great study. Yes.
Dr. Ford, a couple of additional questions have come in through the chat. Okay. Here's one. You stated earlier that minorities see poor outcomes about 10 years earlier than whites, and this person was wondering if you've seen a similar shift in age-related risk of COVID outcomes, mortality, for example.
Mm-hmm. Yeah, so that's a really great question, and I have the same question myself. I have not been able to find data by age and race, because I had the same question. Are the COVID-19 deaths in Blacks occurring at younger ages than the COVID-19 deaths in whites and other groups? Same question. Could not find the data. If someone knows how to find those data, that's a really great question. I can find data on race and on age. I can't find the crossing of the two.
Well, and just to add to the mix, another question came in about potential gender differences and susceptibility to the risk of COVID-19 and or the subsequent severe outcomes, right? So just adds to that intersectionality.
Absolutely. I mean, the earlier data showed that the infection rates were higher among men, particularly white men. But when you look at the death rates, you don't see that trend carried through. Just an infection.
So there was a question about the male outcomes. Has there been any studies specifically of Black males and anti-interferon antibodies? Again, that's a really great question, and I think that work needs to be done. I haven't seen any studies, but I think that would be absolutely great, a great area of research. Sharia Robinson Lane, did you want to respond to the conversation?
Oh, sure. I'm sorry. Can you hear me?
Yes.
I was just commenting on the question that was about differences in age. Our teams is looking at data in Michigan. We have a hospital quality initiative where we're looking at data from 38 hospitals, and we have about 2,200 patients. And so in that data, we saw that there is a age difference of about 8 years between Black and white patients that were COVID positive that may have some effects on their outcomes, both in the hospital and in post-hospitalization.
Thank you. And that's interesting that it mirrors the age difference in diagnosis of chronic disease between Blacks and whites. Around 8 to 10 years. That's a very interesting observation. Thank you.
Sure. And the other thing related to that, keep in mind, is that if that age gap falls before the age 65, then you have a whole bunch of people that are also excluded from the Medicare system and healthcare access.
And that is a major, I'm so glad you brought that up, because when we talk about access to healthcare, that is a major issue right now. So yes, that the lack of access to healthcare is one of the reasons people are are at risk to begin with, and then you get hit with COVID. And the problem with a COVID-19 infection is that more and more studies are showing that there are some long-term consequences of having had a COVID-19 infection. So it's not like you get infected and you get well and then you just go on with your life. There are some people who where it almost becomes a chronic disease. They're still dealing with the aftermath. And my question is, where are they going for care? You know, once they're either released from the hospital for their for the acute care, maybe they go to a rehab facility, but then they're sent home. What happens to them? I think people who are released back to the community, I mean, how large is this number of people who have long-term chronic effects from COVID-19 infection, but don't have access to healthcare? What's happening to them? Where are they going? I think that work needs to be done as well.
Great questions have been asked, and this is a fascinating topic, and clearly lots of work for us to do moving forward. Are there any other questions or comments for Dr. Ford?
This is just really a comment more than anything, Dr. Ford, not a question per se. You know what, I was intrigued by what went through my mind as you talked about the I-95 corridor, right? So before you got into the work I'm sure you've been doing for quite some time about disparities in those areas, I was thinking about COVID specifically and the request to not do interstate travel. So my mind went to 95 corridor, the unfortunate transmission of COVID from one location to another along 95, and would have expected a rise in COVID cases because of that travel feature. And so this is why I think the research is so important for folks like yourself who've been doing this for a while, who know, like, wait a second, that, you know, as a novel viewer to this analysis, you could make a completely incorrect assumption based on what you think the data is saying, because you're imagining one sort of vantage point, right? So it really just a comment, observation, and I was really grateful to hear your talk about really disparities research more broadly in discussion around the 95 corridor, because like I said, I just wanted to reveal to you, that's where my mind went to initially, is of course there'd be higher rates around the 95 corridor because people are moving through that. So thanks for the, you know, bringing the more important information to bear there in terms of pre-existing poverty and the like. Thanks.
Thank you so much. That's a really great point that you brought out. And I think that is important for the I-95 corridor, the emphasis on pre-existing poverty, pre-existing lack of access to care, pre-existing susceptibility to disease, pre-existing health disparities from childhood through middle age to older adulthood. And I mean, unfortunately, we really laid the groundwork over decades in this country of having these issues for Blacks to be so negatively affected by a pandemic. These are issues that have been going on for hundreds of years, and the positive thing, as you said, is that now, you know, we're shedding light on the fact that if we don't address these issues of disparities and lack of access to care and susceptibility to disease, if we don't address them in the Black population, it will negatively affect all populations in the United States. So for many years, we acted as if, well, you know, it's happening over there, so, you know, doesn't really affect everyone. It's important, but, you know, it's like one pocket. But what we're realizing with the pandemic is what happens to one group or what happens in one group affects all of us, because of when we're exposed to a novel virus, it's going to enter a population in its most susceptible place. So in the US, that was, you know, assisted living facilities, but now it's everywhere. And so hopefully the pandemic will shed light on the fact that we have to improve the health status of everyone in our population, because that protects all of us against the next pandemic that's on its way.
Dr. Ford, there was one more question that was asked through the chat. Here it is. California is planning on being proactive with placing Indigenous people on the early group for vaccination. Will South Carolina do this for disparate groups?
That's a really great question. That's great for California. I think in South Carolina, the groups that I just read yesterday that are starting are people in assisted living facility, the oldest old, and I think people with severe health challenges. I think it's the third group. So that will include a lot of Blacks, but I have not yet heard of a targeted effort to focus the vaccine on any particular racial or ethnic group in South Carolina. But I know there's an effort made to, from a blanket approach, target the vaccine to focus it on communities who have the greatest health needs, which will include a lot of Black people.
Dr. Ford, this is Patty.
Yes.
How are you?
Great, thanks. How are you?
Video. I had to join the webinar late, and my question actually may have been addressed earlier on, and please say so if that's the case. That intersectionality between the cultural adoption of healthcare technologies among African Americans and what that means for adoption of the vaccination and the historical perspective of why that is and what types of things could help mitigate that hesitancy. Some of it is probably warranted because the vaccination came out of the blue really, really fast, and the approval process is being extremely expedited. So I can appreciate some level of hesitancy until after all of those safety studies and outcome studies are completed, but there are going to be people who need to go ahead and take it before that data is available. And the importance of continued mitigation measures with the masking and the social distancing and even in the presence of the vaccination. So it's a lot that I threw into that basket, but I'd just like to see if you could speak to that. And if you already did, just say so. I apologize for attending late. Thank you.
No, actually, thank you. That's a great question. It has not come up yet. And actually, I coordinate the Black faculty group at the Medical University of South Carolina, and we just spent an hour and a half talking about that last night. So we agreed that it would be helpful if prominent groups in different communities, let's use the Black community as an example, made a statement in support of the vaccine. We learned that historically Black medical universities have made a statement that they support the vaccine, and they carry a lot of clout in a lot of communities. We are going to make a statement in support of the vaccine, and we're also developing a plain language, one-page kind of fact sheet about the importance of getting vaccinated that community members can distribute at their churches, and we're going to work with our federally qualified health centers to get that information out. But you're absolutely on point. I think the problem that we face is that I don't think we did, we meaning the U.S. as a whole, I don't think we did the best job of educating the community about what COVID-19 is. But now we have a chance to support the vaccine and use prominent figures to get the word out about how important it is to get vaccinated. And we heard an impassioned plea from one of our rheumatologists last night who made the point that Black children, we talk about the age group, that they are ending up in the ICU at much higher levels than white children. And so that really brought home the need for the vaccination, because if you want to convince people, you talk about the children, right, and the impact on the children. So I think that's where we're going to go in our statement and in the one-page plain language fact sheet. And thank you so much for bringing that up. It looks like we're at time now. It's 1 o'clock.
We are at time,
That's
Dr. Ford. Thank you for
Okay.
everybody for
Thank you.
joining us this morning. Thank you, Dr. Ford, for your wonderful presentation. For our participants, please note that we will be sending out an evaluation for today's webinar, and please take some time to give us your feedback. These webinars are made for you, designed to stimulate good discussion and provide good information that's relevant and timely. So please respond to that. Thank you again. Thank you to Dr. Ford for being with us today. Thank you for those that joined us on this webinar. Thank you to our Coordinating Center, and thank you for the NIH for supporting our efforts. Have a great